Well, it is a pleasure to be able to have an in-depth discussion about the most recently published 2025 AHA-ACC scientific statement on clinical considerations for the athlete with cardiovascular abnormalities. My name is Dr. Jonathan Kim, and it was a real honor to lead this with two of my closest friends and colleagues who are with me here today, Dr. Aaron Baggish and Dr. Ben Levine. So welcome, gentlemen. And let's dive right into this. I think just to start off, this is several iterations into recommendations focused on the competitive athlete with heart abnormalities. But different within this version was that this was truly a collaborative and equal effort, not only amongst the three of us, but really a team effort amongst everybody that was involved. So we're going to take a deep dive into many aspects of this. But I think to begin with, we have to talk about some historical perspectives. And the perfect person to begin this discussion would be Dr. Levine to take us back through the Bethesda conference proceedings. Ben.
Thanks, Jonathan. Well, the Bethesda conferences were started back in the mid-60s, and they involved getting a group of experts together for 2 or 3 days in Bethesda at the Heart House to provide guidance to the cardiovascular community. And the 16th Bethesda conference, which occurred in 1984, was focused on the management of athletes with cardiovascular disease. They invited experts from all around the country to get together to talk about not just hypertrophic cardiomyopathy, but to provide a broader perspective on management of athletes with heart disease. Those Bethesda conferences were repeated just about every 10 years. There was the 26th in 1994. That was the first one that I participated in. The 36th was done in 2004, and then the next one occurred in 2015. And I think that's when Aaron really started to get more intensively involved in the process. And so I'm going to turn it over to him to sort of bring us up into that modern era.
Thanks, Ben. That history is incredible in terms of setting the stage for this discussion. I think if we pick up with the 2015 guideline, it's important to recognize that it was still named a disqualification or a sports determination document. You and I were both on that paper, not in a leadership role per se, but playing a role in the writing, was really again geared toward figuring out who to disqualify and who to permit to play sports. So a couple things that were pointed out in the 2015 document. First is that all of the recommendations were regarded as generally conservative. And it was put forth at that point that a conservative posture is prudent when there's limited available evidence. Basically, that if the data are not concrete to help a doctor make a decision for a patient, that it's best to be conservative. Now, let's be clear. In the last 10 years, the field of cardiovascular medicine, the field of general medicine for that matter, has evolved away from thinking about those areas of uncertainty in which either conservative or paternalistic care is the best approach, to acknowledging that when we don't have the data to be clear about the right decision, that's really where the patient's voice and the patient's involvement in their own trajectory becomes really important. And that's really where the term shared decision making is now the foundation of the new document is so important. I do want to point out that shared decision making in the sports cardiology world is not new. Certainly it's gotten a lot of traction over the last 10 years, but even in 2015 with the last iteration of the Bethesda conference proceedings, which for the first time then was a shared ACC-AHA document, there was still not a single mention of shared decision making. There was an acknowledgement of flexibility and the concept of individual assumption of risk, but that document was very much still a compendium of who should play sports and who should not.
Well, thank you, Aaron. And I think that really is a nice segue then into 2025 and what the three of us, just led. So all of you, I think, really summarized nicely some of the quote unquote why, right? We've had 10 years of science, which I think you also alluded to, Aaron, as well, over the last decade. We also recognize the explosion of sports cardiology. And I think the two of you mentioned this as well. And really, in the end, the demand has outpaced supply. And the 2015 document really pitches for some recommendations that in the higher spectrum of sports cardiology care is really not consistent with what we do. And so the quality that's out there for athletes across the board just wasn't there. And so with all of this put together, there was a clear need for this document. So let's get into the weeds about format now. This document is very similar to the 2015 in the sense that we organized task forces to go over the specific cardiac disease processes. But really, big picture, when you look at ACC and AHA, there was a fundamental shift away from big documents. So our task was to take the 2015 document and condense that down into about 10,000 words. So it was really quite daunting. We did our best. But these subsections, which were still led by task forces, really did a nice job of putting forth these clinical considerations while also giving a summary statement. We should also emphasize that we wanted to make this both internationally diverse as well as just diverse across the board. So we see this as you look at all of the task force members that were a part of this, and I believe it was 48, with roughly 11 people, I believe, that led specifically these task force sections. We also have to talk about the fundamental shift from ACC and AHA away from the class of recommendation level of evidence that's present within guideline documents, but not now present within scientific statements. And in some ways, I think we led probably the first of these documents. So we wanted to still allow the reader to be able to understand these clinical considerations with the mindset of how people read guideline type documents. So when they read these clinical considerations, they see verbiage that they can then relate to what a guideline document previously stated, such as class 1, 2A, 2B, and class 3. So early up front within this document, we have a table with specific verbiage used, and we define these, which are kind of equivalent to how one thinks about guidance within a true guideline type document. So we use words such as should not, and can. These are really words that highlight medical standards of care, things that every clinician should do or clinician should not do, which could harm a patient, as well as considerations that are backed by strong evidence. We then use terms such as reasonable to consider, and can consider. So these are kind of similar to how we think of those 2A, 2B recommendations. The reasonable is a word that equates to having some levels of evidence out there, but also backed by consensus within the expert community that cares for athletes. So kind of akin to your 2A type recommendation. We use reasonable to consider to hit that gray zone between a 2A and a 2B recommendation, where there's some data, maybe limited data, but there is science that's out there. So it isn't just expert consensus opinion. And then the can consider, which is very consistent with language used to support a 2B recommendation, which is a recommendation that's really just expert consensus. So we don't have the data, but it's supported by the expert faculty, the expert clinicians out there who are taking care of these athletes to support that recommendation. And we even have levels within class 3. So these are things that are generally considered things you really shouldn't do, but understanding that maybe there's not strong data to support saying that you shouldn't do these, and still supporting the need to proceed with shared decision making. So we have terminology such as risks likely outweigh benefits for competitive sports, or risks may outweigh benefits for participation in competitive sports. So kind of two layers for the clinician to think about whenever there may be some situations where there's not a ton of data to support, it's a little bit in that gray zone, but we're trying to guide them to just acknowledge that there are probable risks if that athlete participates in competitive sports. And to Aaron's point, these are not disqualification recommendations, clinical considerations at all. So now we're going to shift into some of the specific updates. We're about to talk about shared decision making, which didn't exist before, and this was a highlight within this document. But we also have other changes as well. We had a bigger focus on the aorta, and we separated that section into to have a little bit more clarity and conciseness to that. We have a section on the master's athlete, which is brand new. And then lastly, a section kind of on the miscellaneous categories as well, where we talk about populations not previously considered. And we'll talk a little bit more about that later in this discussion. But let's go through the highlights. And First, let's talk about subsection 1 or task force 1, where we talk about changes in sports classification, an update from the previous Bethesda as well as the 2015 scientific statement. And the best person to talk about this is, of course, Dr. Levine, who's led all of this over the years. Ben.
Thanks, Jonathan. Thanks for that great summary. The original guidelines and tables were set up by Jerry Mitchell, and his approach was to say, okay, what are the adaptations that we see in the heart related to the type of exercise? And that's where he thought about, what had used to be called the athletic heart. Now, I think we're happier considering that exercise-induced cardiac remodeling to make it clear that there's not just one particular form of an athlete's heart, but that those were graded with more volume type loading and dynamic exercise and more pressure loading with static exercise. That model also, I think, has been demonstrated to not be so clear. And so in the most recent guidelines, we've tried to remove those bins and acknowledge right up front at the beginning of this document that sports is really a continuum, that the amount of load on the cardiovascular system changes. It changes based on position. It changes over the course of the year. It changes in the playing of the sport, and it changes with the training of the sport. And different athletes will have different components of strength or static exercise and endurance or dynamic exercise. So our new table is really designed to eliminate those categories or those discrete bins, and that helps to avoid the proscription to say you can only participate in a 1A, but now I think we've put the onus on the task forces to say, all right, what do you mean by that? How much dynamic or endurance exercise is too much or too risky? How much strength exercise is too risky? And try to put the considerations into a more general flavor of how sports are conducted. One of the big changes over the last decade has been in anticoagulation. And so, in the original documents, there really was mostly just aspirin and Coumadin. There really wasn't much else. We now have a proliferation of medications that are more or less intensive at blocking platelet activity. There are direct oral anticoagulants, which have really replaced Coumadin under most circumstances and which have a half-life that allows for a little bit more thoughtful consideration of how that should be used. We also have tried to clarify what that means or what kind of sports provide risk. I mean, there are sports where collision is clearly a major part of the sport, like American football, for example, or ice hockey. There are sports where collision is when it occurs, is pretty disastrous. In cycling, for example, where you have a crash, but that's not part of the sport, but it can happen. And the same thing with alpine skiing, for example. So we've now created a red, yellow, green type table, which gives a better sense of when bleeding is at high risk and when different levels of anticoagulation are going to be more or less important. So those, I think, are really the two big changes in our Task Force 1 or classification of sports. Eliminating the bins and presenting the sports on a continuum of endurance versus strength exercise, and then providing I think, a more helpful table about what the nature of anticoagulation might be and when it would risky or not so risky in different sports.
And of course, the foundation of this whole document is already alluded to shared decision making. And we want to have an opportunity to really dive more into that because it's so important. And Aaron led this subsection / task force. So Aaron, take it away.
Yeah, Jonathan, thank you. I mean, this is, in my humble opinion, probably the most important addition to this series of documents is now what we call Section 3, which is the ethical aspects of competitive sports eligibility. And what it first does is it presents a working definition of shared decision making, Put very simply, shared decision making is the process by which patients and clinicians work together to define reasonable decisions. Nothing's right, nothing's wrong, but something is reasonable for the patient and the doctor who work collectively. The second thing that we talk about in the document, which I think is very important, is that shared decision making doesn't antagonize, it actually aligns perfectly with the four major ethical tenets of justice, autonomy, beneficence, and non-maleficence. These are things that in the past have been looked at as impediments to shared decision making, but I think one of the things we really wanted to make clear is that if you adhere to those medical ethical principles, shared decision making is not a choice, it's not an option, it's an ethical imperative. Within the document, and again, we'll be, I think, continually encouraging people to read the full document because everything we say today can't really do justice to how much is in it. But there are two workhorses. There's Table 5, which contains 11 items that walk through the rationale and then the clinical approach to shared decision making for competitive athletes. And then there's a figure. I think it's figure 2 or 3. I don't recall correctly, but the figure is actually a how-to guide. And this is important because I think many of us that practice in this space get asked all the time, okay, Dr. Baggish, you tell me to do shared decision making, how do I do it? And what we tried to do in this document is put forward an algorithm. And again, no algorithm is perfect, but I would submit that this is the general approach that most of us use. And if I might summarize briefly, the algorithm contains 3 phases. Phase 1 is just good doctoring. It's confirming that the diagnosis in the patient you have in front of you is accurate, performing whatever disease-specific risk stratification is guideline indicated, and then in situations where therapeutic intervention is relevant, taking the steps to do so. That's just good doctoring. Phase 2, which is where we move from the science of medicine to the art of shared decision making, is all about education and risk assessment and stakeholder involvement. And this, again, somewhat complicated in clinical practice, particularly when you're just getting started with it, but it's really about the process of educating both the athlete and the athlete's family and key stakeholders about the disease and what's known and certainly what's not known about the disease. It's then time to evaluate the athlete's personal values, their preferences, and also getting a sense of their individualized risk tolerance. Are they high-risk individuals versus low-risk individuals? And then finally in phase 2, bringing stakeholders into the discussion and doing so early. And stakeholders include other members of the family, coaches, athletic trainers, general internists, team physicians, school administrators, in some cases lawyers. The sooner we get these relevant stakeholders into the discussion, the more likely we are to reach a consensus up front and not have residual problems after the athlete and the doctor come to their personal decision. And then finally, the last phase of the shared decision-making algorithm is about the decision itself and implementation. And I want to make an important point about shared decision-making, and that is that there are 2 very reasonable decisions that every doctor and their athletic patient can come to. The first is that competitive sport participation is no longer in their future best interest. And in that situation, the algorithm clearly states that the doctor's responsibility is then to work with their patient to figure out health-based exercise for life. Even if competitive sport is removed, we have a duty to our patients to keep them physically active and to do the amount of physical activity that's best for their health and wellness. For those competitive athletes that do choose to continue with sport participation in conjunction with their doctor, the steps that are laid out include having an available emergency action plan, coming up with a return to participation conditioning plan, particularly for those athletes that have had lengthy diagnostic evaluations during which they may have lost conditioning and competition readiness, and then finally having a comprehensive longitudinal clinical surveillance plan in place so that the athlete and the doctor don't just make a decision in part ways, they make a decision and come together at routine intervals to reassess the severity of the disease process, but also where the athlete is in their thinking about continued competitive participation.
Well, thank you, Aaron. Thank you, Ben, for those very detailed descriptions of sections 1 and 3. And as people listening to this can imagine, we couldn't possibly give that breadth of detail to all 11 sections. We wish we could. We'd be here for a long time, though. We want people to read this document. So we just want to finish off with our highlights discussion here with just some of the key highlights. Again, acknowledging there's some important clinical considerations that we're not going to mention right now, but are really important for people to read up on because really throughout this document, there's changes across the board. This is such a game-changing clinical reference document. But what are some of the key changes? Well, let's talk about pre-participation screening, the debate that will drive this field probably forever and ever, and certainly well past our careers. And we certainly don't answer the debate and tell you that there's a definitive right answer. But what we do acknowledge is that there's certainly an amount of science that's evolved over the last 10 years, which has told us that the inclusion of a pre-participation ECG to an asymptomatic athlete, in addition to a well-performed history and physical, actually does improve the sensitivity of picking up conditions that may potentially increase the risk of a adverse cardiac outcome. Again, we don't have the data to really support that ECG screening saves lives. And I know Dr. Levine always wants to emphasize that important point, and it is true. But because of these data, we acknowledge that ECG screening is reasonable. Again, refer to table one, what that means, reasonable to proceed with as long as you have the right person reading the ECG, the right people overseeing the screening program, and ensuring that you have equitable resources once you have that abnormal ECG. The worst thing is to hand an ECG to a provider and say, okay, it's abnormal, and that person has no idea what to do. That's when ECG screening can be dangerous. But it is a change in terms of how ECG screening has been discussed and recommended in prior documents. Genetic cardiomyopathies, this is the big one, right? So what's the key conclusion when you think about HCM, DCM, arrhythmogenic cardiomyopathy? There should no longer be a uniform mandate of disqualification. And by the way, this is consistent if you look at HCM guidelines that have evolved. So this is really playing catch up, but it is something major when you look at documents talking about clinical considerations for the competitive athlete. When we talk about myocarditis, the 3 to 6 month, totally made up based on animal data. I think rats, if I recall correctly, no human data. It's carried forth in guideline after guideline, consensus statement after consensus statement. There are some data to suggest, if you look at athletes recover from COVID-19, that perhaps the inflammation can resolve much sooner. And so what we state is that there can be a return sooner than 3 months as long as you ensure symptoms have resolved, myocardial inflammation has resolved, and there's no evidence of arrhythmia or inducible arrhythmia. So some data actually to support that change. Major changes when you think about the aorta, very conservative recommendations in the past. In this document, we are much more streamlined. We talk about bicuspid aortopathy. We talk about hereditary thoracic aortic disease, gene positive, gene negative, but never discussed in prior documents the unexplained enlarged aorta or aortic aneurysm. So that is discussed in detail in this document. And all I can say is at least we are not as conservative as what has been pitched forth in the past. Again, acknowledging that the data to support all of these uniform disqualifications for athletes with bicuspid valves and aortas of 4.2 centimeters max dimension, really not supported by data, perhaps too restrictive. And then lastly, Task Force 11, Section 11, the miscellaneous conditions. So within this, you'll find commotio cordis, hypertension, things such as these conditions, which have been discussed before. But we talk about conditions not previously discussed. Pulmonary embolus, we talk about athletes who are engaged in more extreme type sports, exercise at altitude, the recreational athlete engaged in scuba. And we talk about the healthy athlete who's pregnant. So something that's never been discussed, and at least opening the door to let's talk about this healthy athlete and how to consider when an athlete is pregnant and they want to continue with competitive type sports. So all of this is within the document. I'm going to conclude this discussion, of course, just to thank Aaron and Ben again. Mentors for me for my entire career. And so such an honor to work with them on this and lead this with the two of them as well. This was really a try effort, if you will. I do want to also thank the writing group, which these are the primary co-authors that are going to be listed on this document. And I obviously can't list the 48 contributors, but I have to say that this document would not have completed to its end without the input of all of these people. We certainly didn't make these clinical considerations across the board. Everybody within their area and arena of expertise was critical to all of this. So the last reminder for all listeners, please read every word of this document. The mandate from ACC/AHA was to shorten these because they felt it was too long, these prior documents, and nobody had the bandwidth to read these very lengthy documents. And so there's no excuse because really every word within this document has importance. And with that, thank you so much for your attention and listening.